Good afternoon. I'm Catherine Santoro, Director of Policy and Development at the National Institute for Healthcare Management Foundation, and on behalf of NIHCM, welcome to our webinar today. We're pleased to have an excellent panel of speakers with us to share their perspectives on the potential for mobile health technology to improve care for Medicaid patients. Before we hear from them, I want to quickly thank NIHCM's President and CEO, Nancy Chalkley, who led the development of today's webinar, as well as the NIHCM staff who helped to convene the event today, including Kate Ellis, Katie McDonald, Carolyn Myers, and Kirsten Wade. You can find biographical information for all of our speakers, along with today's agenda and copies of slides on our website, www.nihcm.org. We also invite you to live tweet during the webinar today using the hashtag #MobileHealth. I'm now pleased to introduce our first speaker, Dr. Don Berwick, President Emeritus and Senior Fellow at the Institute for Healthcare Improvement and a former administrator of the Centers for Medicare and Medicaid Services. Dr. Berwick is a leading authority on healthcare quality and improvement. We're so honored to have him with us today to share his perspective on the potential for mobile technology to accelerate the redesign of the healthcare system and achieve the triple aim. Dr. Berwick?
Thanks so much, Catherine, and thanks everybody for joining. It's a wonderful turnout for an exciting topic. Although our focus is on Medicaid today, I'm going to say right at the start, I think the topic we're talking about has to do with healthcare delivery reform and transformation right across the board. Medicaid may be the most charismatic or exemplary area to work on right now for a lot of good reasons, but this is about healthcare delivery as a whole. My comments are going to set the stage for the real experts who understand the use of this technology. From the viewpoint of improvement, which is always my viewpoint, the first thing you need is aim, and I just want to touch base again with what I think is the social need. All of the stakeholders, caregivers, and clinicians, insurers, plans, everyone needs to rally around a set of goals which were first described in 2007 and 8 by my colleagues John Whittington and Tom Nolan as the triple aim. This reflects what the social need is from health and healthcare system. It's better care as originally anticipated by the Institute of Medicine, crossing the quality chasm. That's care that's safe, effective, patient-centered, timely, efficient, equitable. The second of the triple aim is population health, working upstream against the causes of ill health and deterioration of health in chronically ill people especially. And the third aim is to reduce cost, to reduce per capita cost, not through rationing or withholding anything at all, but to reduce costs through improvement. That, to me, is the goal that should be uniting us all across the board, all stakeholders. The Institute for Healthcare Improvement, where I now serve as Senior Fellow, has begun a program called the NIHCM Leadership Alliance, which currently involves 42 American healthcare organizations, and there'll soon be a European version of this, to work on radical redesign to achieve the triple aim. The fundamental idea here is really key, and that is that the current healthcare system, as it performs, as it functions, as it's designed, cannot achieve the triple aim. It's incapable of it. You could yell at it as loud as you want, but it can't get better care, better health, and lower cost. It wasn't designed to do that. From the viewpoint of quality improvement, my field, the route to improvement is always redesign. It's always change of delivery, in our case, change of the way the healthcare system functions. You can yell at the system, you can change its incentives, you can wish it would be better, but nothing will happen until the care itself changes. And that's what brings us to our topic today. Now, the NIHCM Leadership Alliance has dealt with this in terms of redesign principles. I want to show them to you very quickly. This is 42 organizations coming up with a set of 10 principles which would provide the foundations for the redesign of delivery, much as an architect's drawing might have elements that will eventually amount to a house. Let me show you the principles quickly. The first one is change the balance of power from a professionally dominated, kind of professionally controlled delivery system to one in which professions are in a far more equitable relationship with the people they serve. The second is standardization, not standardization of everything by any means, but standardization where variation doesn't make sense, where there's a right way to do it and it should be done that way every single time. But the third is an apparent contradiction, customization. It's customization to the needs of every single individual patient, family, community. That tension between standardization of what makes sense and customization to individuals marks a mature industry of any type and should mark healthcare. The fourth design is to move upstream, promote well-being through intervention not just in the effects of illness, but in the causes of illness, which involves a reorientation of healthcare that's profound. The fifth is a bit of surprise, perhaps. It has to do with the healthcare workforce. Designs that demoralize or demotivate or exhaust the workforce are not sustainable, and they will not achieve the triple aim. Focusing on joy and pride in work is a design principle for the healthcare system of the future. The sixth is one of my favorites. It's make it easy. It's the identification of barriers to the workforce to get their job done right, and barriers to patients and families and communities to get access to help, both better health and better health care. This is one of my favorites. We had a Make It Easy week, a Breaking the Rules week. We called it about 2 weeks ago in the Leadership Alliance. 42 organizations produced more than 350 ideas for rules that make no sense, things that could go away and thereby help them achieve the triple aim better. The next principle is move knowledge, not people. That's the core principle we're discussing today. It has to do with revealing visits and admissions as often the dinosaurs they are, in which just as we access help in our lives through many media other than face-to-face encounters, the same potential lies in the redesign of care. The next principle is cooperation across boundaries, probably the fundamental rule for improvement. And the next to the last is assume abundance. Stop asking for more. American healthcare, especially at 16, 17, 18% of gross domestic product, has much more than it needs to get the job done. And changing that mentality is part of the design, and then returning the money in the form of lower premiums to individuals, to labor, and to employers, and lower cost to government. These are the radical redesign principles being explored and put into effect by the IHI Leadership Alliance this year and in the years to come. I'll give you a quick example of what these look like in action. My favorite of all, possibly, is the South Central Foundation's NUCA system of care in Anchorage, Alaska. South Central is the Alaska Native corporation that owns and runs the care for 60,000 Alaska Natives. It's highly recognized for its achievements so far, and its achievements are stunning. They're all based on the redesign principles I just showed you. Fundamentally, for example, team-based care, highly cooperative care. This is the doctor's office at NUCA. It's a doctor you're looking at, but also a nurse and a nutritionist, a physical therapist, a behaviorist, pharmacists. They all work together. NUCA is completely team-based care. That's a fundamental design principle. These are NUCA results between 2004 and 2009 for 60,000 Alaska Natives. 50% decline in emergency department use, 53% decline in hospital bed days and admissions, 65% decline in special utilization, and even lower primary care utilization with enviable quality scores, employee satisfaction, and patient and family satisfaction. It can be done through redesign. Now, as I showed you, one of the core redesign principles in the 10 that the Leadership Alliance is pursuing is move knowledge, not people. It has to do with the development of non-visit-based care, primarily non-visit-based help, and investment in technologies like telemedicine and telehealth that help get that job done. Here's a stunning example of this at work. This is Project ECHO at the University of New Mexico, formed and led by Dr. Sanjeev Arora. Dr. Arora is the guy in the tie seated at the head of the table in the upper left-hand picture. Arora is a hepatologist, an expert in hepatitis C management, who years ago recognized that as a referral specialist at the University of New Mexico, he couldn't take care of more than 1 or 2% of the hepatitis C patients in the state of New Mexico. But he thought that using what he calls force multiplication, this is extension of help out through telemedicine, telehealth, he could do better. The small screens on this shot show you the direct synchronous connection that Dr. Arora has every week with literally dozens and dozens of primary care clinics, some just nurse staff throughout the state of New Mexico, in which care is being provided to people with hepatitis C, very technically difficult care, without the patient ever moving. The knowledge is moving out to the care providers in the periphery. Dr. Arora has covered the entire state of New Mexico, and by the way, other states now as ECHO has expanded with this kind of help, and not just for hepatitis C, now for HIV/AIDS care, suicide prevention, for obesity work, for work on care of the frail elderly. I visited ECHO, and I've seen the studio. I've sat there as Dr. Arora and his colleagues have coached scores of care providers in many locations using what he calls telehealth, and the results are fantastic. At much lower cost, Project ECHO is, for example, achieving viral eradication levels for hepatitis C with the ECHO patients managed only remotely, better viral eradication than for the patient to get referred to the University Medical Center. This is the future. Here's another wonderful example. This is a cell phone-based technologies. We'll soon be hearing from our other guests. This one is called Peak. It was developed by young ophthalmologists at St. Mary's Hospital in London, England. Through a simple device attached to a cell phone, they can now do retinal images, for example. This is a retinal scan being done on a man, I think, in Pakistan, and being read at St. Mary's Hospital in England. The visual quality, the quality of the image obtained through the cell phone is better than the quality of the image obtained in the multi-$100,000 machines at St. Mary's Hospital in Paddington, London. Peak is also leveraging its efforts by reaching out to workforce development. For example, they had a project in which they screened 10,000 children for visual acuity in Kenya, but the screening was not done by ophthalmologists or optometrists. It was done by their own school teachers in less than 1 week using a mobile technology. This is the triple aim. It's better care, better health, and lower cost altogether. One final example I'll give you, I did it with a little caution because this is a for-profit effort as opposed to the others I've shown you, is Lemonade Health, which was recently developed by a friend and colleague of mine, Bonnie Zell, and I think it's a game changer. Lemonade has now identified, in this case, 8 conditions which can be dealt with synchronously and asynchronously by patients who log onto a website. This is not mobile phone. This is a website-based technology, but in very rapid order. Management and pharmacotherapy for acid reflux, for acne, for birth control, for erectile dysfunction, and so on can be managed by Lemonade with highly certified doctors, high levels of quality, at a cost of $15 per visit, and I think they would like to have it be even lower than that. I think that's the future. This is about big deal redesign. The 10 principles of the IHI Leadership Alliance, for example, it's a migration, it's a transformation of healthcare from fee-for-service to global budgets, which provide the economic foundation for what I'm showing you, a recentering of healthcare from the hospital to the home. Kaiser Permanente uses the phrase, home is the hub, and I love it. It's the new system. From soloists who one by one deal with patients to high-performing teams, like you can see at the NUCA system in Anchorage, and moving knowledge instead of moving people, and beginning to understand that there's a modern age of information management which can completely revolutionize both costs and quality. It also is much more patient-centered. My colleague Maureen Visigliano, the former CEO of IHI, says that we have to shift the system from one that asks the patient, what's the matter with you, to one that says, what matters to you? And I believe that these remote and telemedicine, telehealth technologies can be much more patient-centered, much more under the control of the person being helped. And by the way, we can stop asking for more. These are generally highly efficient systems that I think will leverage our dollars far, far further. I personally put out a goal for America myself. I'd like to see us get to 15 or 14% of gross domestic product and return that money to other uses. And we can do it if we're smart about redesign. That's the background I'd like to set. The real experts are the others on this webinar. I'll be remaining connected and look forward to questions and answers later on in the show. But back to you, Catherine.
Thank you so much, Dr. Berwick, for that introduction and for your continued leadership that inspires so many leaders working to improve the quality of our healthcare system. We'll now move into our panel of examples of mobile technology being used for the Medicaid population. Our first speaker will be Erhardt Preitauer, CEO of Horizon New Jersey Health, which serves about 1 million Medicaid and Medicare members in New Jersey. Under his leadership, Horizon New Jersey Health has become a national leader for its managed long-term services and supports program, and we're so pleased he's with us today to share their award-winning and innovative use of mobile technology in this program.
Thank you, Catherine. And I'm joined here with Jerry Boone, who runs much of our managed long-term services and supports program. So just a quick introduction. We oversee about 1 million government programs members, and you see that at the top of the slide. About 700,000 Medicaid and about 140,000 age-blind, disabled, or managed long-term services and supports members. And we've been serving these more challenging and technical populations for several years now at this point. Part of why I came to New Jersey a few years ago was really because we had the opportunity, I think, to build, from a long-term care perspective, one of the best programs in the country, in my opinion. And I've had the opportunity to work in many, and we'll certainly talk more about that in the following slides. So I think one of the things that's important as we think about technology, I mean, it really is an enabler. And I think this statement really summarizes sort of our viewpoint, and it's very important, I believe, from a cultural perspective for an organization to really think of themselves a little bit differently when we're working with some of our highest needs members of our society. Dr. Berwick talked a little bit about that earlier, and I think our approach and sort of what we're going to go through here really shows that proactive care management with mobile technology really can work and drive down costs and increase quality at the same time. So we really look at ourselves in terms of bringing the whole health plan out to the member. We think of ourselves as a social agency, and then, of course, being able to leverage technology. And it's certainly been recognized. We're very proud of the recognition that has been recognized by some of our partners. One of the groups that has moved into managed care in the last couple of years are the TBI folks supported by the Brain Injury Alliance of New Jersey. And in fact, they've are recently recognizing us for the great work we've done in terms of increasing the coordination and quality to the members that they serve and minimizing disruption. And then, as you can see to the right, we've received some technology awards from a couple of leading publications that we're very proud of as well. So this next slide is kind of an overview. But in a nutshell, what we've done is we've taken the full power of a health plan and we've made it mobile. So we're able to take a mobile system out into the community where our members are, under bridges, in their homes, in nursing facilities, and perform basically all of the functions that we could in our office in a health plan. But what that does is really important. It fundamentally changes the conversation that we can have with a member, because we can see in real time practically everything that's going on with that member. In addition to that, what's very exciting is we can perform assessments real time out in the field, and behind those assessments we can dynamically create care plans, and behind those care plans we can actually even have the care coordinators trigger authorizations and order services. And one of the things that we're really proud of is the care plans and the services and the providers that we're talking about go far beyond just the traditional providers. We've put a lot of effort into the community and the social service and the providers that are in the communities that we're serving. So it is truly a very holistic approach that we take out to the member. But doing that's very, very tricky. And I'll give you an example, a couple examples, and I think Jerry here will have a couple of examples as well. It's not easy, right, to take a mobile device out and have all of that access. I'll give you a few examples. We have to have our nurses out in the field with Wi-Fi access, and they have to have telephone access. Some counties in New Jersey have the ability to have a phone where you can have Wi-Fi and phone at the same time. Other counties in New Jersey will only allow you to have one. So we might have a nurse that is halfway through her 500-question assessment, and she receives a phone call and gets kicked offline. Obviously, that can't happen, so we've got to be able to plan for that. There's a lot of those little nuances as you go through workflow and planning that you've got to be able to manage. It sounds like a minor deal, but obviously you can only imagine the frustration that a nurse might have if they're halfway through a question assessment, and then, of course, not to mention the inconvenience to a member. What happens if you're in an apartment building and you can't get any connection whatsoever? All of our assessments are able to be offloaded onto the hard drive of the computer for a short period of time. But if you do that, what about security, right? Security is a huge deal. Tons of sensitive information. We've all read about the challenges that some other health plans have had around data security, and certainly our data security people struggled a little bit when we told them that we were going to take all of this out into the field. But you've got to have the highest level of security around all the sensitive information that we have access to and the sensitive information that we're gathering for our members. So there's a lot to think about as we look to take technology out into the field.
Hi, everyone. This is Jerry, and just following up on Erhardt speaking about the offline capability, you know, that was really key in a lot of our successes, having that offline, so the care manager can fill out the assessment. As soon as she's back online, she exports that document right into our medical management system. It is key that we have everything that we need to know about that member at our fingertip. We have claims information, we have pharmacy information, we have their backup plan, we have the most up-to-date information. We regard ourselves as being a paperless care management system, that we're not carrying folders and mounds of documents with us, you know, that could put us at risk for losing PHI on a member. Everything is within the system. But most importantly, we have access, members have access to us 24/7, and in that access period of time, that care manager who may be caring for them may not be the person on call or may not be available to take that member's question or inquiry or identifying a gap in care. No matter who that member speaks with, they all have access to that member's information, and in particular, their care plan, their backup plan. So if something should go wrong out in the community, they can act on that immediately. And that's really key for us to really making sure that on a 24/7-day basis, we are providing the best care that we can give to any one of our members.
And, you know, the bottom line is, you know, taking the power of a health plan out to the field is tricky, but one of the things that we're very proud of, and this goes again to Don Berwick's comments earlier, is technology is supposed to help make things simpler. And I've been involved with several launches of ABD, or Managed Long-Term Services and Supports programs. And when we went live with the program in 2014, we launched, I think, probably, about 175 care managers out into the field, plus or minus at that time. Brand new technology, brand new job, brand new processes, and I think our turnover was less than 10% for the first year, which is tremendous, especially given the experience of some of the other health plans in the market. But really, you know, the key to that was good support, and it was really leveraging technology to make the care coordinators' jobs easier, not harder. And I think that was a key element to being able to be very successful. And you can see off to the right just some statistics about what we've done over the last 18 months in terms of some of the activity. And on that notion of activity, picture this. For our more complicated members that we manage in the community, either through our internal policy or our state contract, we have roughly 20 steps that we have to manage depending on what the members' needs are. And most of the steps have some level of interdependence. So we get a new member, we've got 3 days to reach out to schedule an appointment, then we've got 5 days to see them, so on and so forth. And so it's critical that, number one, you're able to manage productivity. We've got a lot of folks out into the field. And number two, be able to manage compliance. And so we've built a great tool set, really the best that I've ever seen, where each care coordinator, each supervisor, each manager, through their mobile device, can open up these dashboards and focus exactly on what they've got to do for that day across their entire caseload. So it's really an amazing tool, and something that our entire organization uses very often. But again, it's an important part of the entire mobile picture that we use. There's one innovation that I want to highlight that we think is important, that we're very excited about, and this plugs into our overall strategy. And this is using an app, basically. So personal care assistants for non-skilled home care, obviously a very important part of the post-acute long-term care ecosystem. And there's a couple of opportunities within this provider set that has brought about this innovation, which I'll talk about here around an app. So number one, we ask ourselves, is there a way to leverage the personal care assistant to drive quality in the home? We think about who has influence over the member. These personal care assistants often are with a member several times a week, several hours per day. So that's a question that we thought a lot about. Also, if there's a change in condition in the home, could we get that information from the personal care assistant? We think that the personal care assistant, practically better than anybody, knows if the member's changed or if something in the environment has changed, if there's food in the refrigerator. So how do we leverage that information? From a health plan perspective, I'd like more visibility onto what's going on in the home, what the care plan that they're carrying out is. And of course, there's a lot of focus on reducing fraud, waste, and abuse. So we've created a pilot with Beata, and Sync is the company that we partnered with to create this, where personal care assistants are able to go with a mobile device, so a smartphone. They're able to open their appointments for the day, have the software give them a map, very easy. But when they check in, when they walk through the front door and they check in, it obviously geo-stamps them, so electronic visit verification, not a huge deal. It geo-stamps them, and then it asks them, pushes them a message. Hey, if you can get your member to go to a primary care provider in the next 3 weeks, we'll give you $30, something along those lines. And then the personal care assistant goes through their daily tasks. They fill out their care plan in the app so that we can see that. When they're ready to check out, they check out. Again, it geo-stamps it. And we ask the personal care assistant if there is any change in condition, realizing that these are non-clinical folks. And then if they say yes, however, that information comes directly back to the health plan. And then, of course, we can have the member sign off or thumbprint or picture as a validation that the service has happened. So relatively basic from a technology perspective, but connecting the health plan, the agency, the member, and the personal care assistant in a way that we think is unique, in a way that can drive quality, in a way that we think will get the health plan better involved and reduce fraud, waste, and abuse. We're very excited about that. We've run the pilot since early October. The data is very clear. This is working. So we wanted to share that with you as well. Any additions?
Nope, I think you covered it. Right.
So finally, you know, the putting it all together, I think, again, sort of ending back philosophically speaking, we think our care management staffing, how we staff them, the ratios we staff them with, really were best in class. So we really invested in our care management capabilities, the technology and the people and the experience. We've got Jerry and myself and others with a lot of experience in working with challenging populations. So bringing all that together, and again, the data is out there, and our medical expense is sort of the best in class here in New Jersey. So I am super proud of being able to say we invested more in caring and working and supporting and coordinating for these members. We invested more, and the outcome is lower cost, and the quality metrics that we're looking at are very, very promising as well. So that's a quick overview of a little bit about what we're doing at Horizon in New Jersey.
Thank you both so much for sharing that information, and I know we'll have some questions for you. We'll save them till the end, but thanks for staying with us. Our next speakers, and I'm going to introduce both of them, Dr. Jeffrey Schiff, Medical Director for Minnesota Healthcare Programs at the Minnesota Department of Human Services, and Vineet Singal, co-founder and CEO of CareMessage, which is a nonprofit organization that connects healthcare organizations with mobile technologies to improve health literacy and self-health management. And we're excited to have both of them with us today to share how Minnesota Medicaid is using mobile technology to improve quality measurement through an innovative partnership with CareMessage, and to also learn more about how CareMessage is improving health outcomes in the safety net population through some other partnerships. So first, I'll turn it over to Dr. Schiff.
Thank you, Catherine, and it's a pleasure to join everyone on this call today. I put on a stagecoach and a train on here because when the stagecoach took 3 months to get across America and the train took 3 days, it was pretty revolutionary, and we're hoping that using mobile technology for patient-reported outcomes has the same sort of impact where we can greatly enhance and make it much more productive to measure patient-reported outcomes in a meaningful way. I want to tell you that I appreciated the key points from Dr. Berwick, and I think that this has the capacity to change the balance of power in our system if we can actually move to a truly timely patient-reported outcomes. I work clinically in the emergency department, and the technology that we all talk about, the mobile technology, I joke around that since smartphones have come into existence, our patients don't complain about waiting because they have something to do. So the smartphone is really very much a part of the culture, and as I'm sure Vineet will talk about, is a big part of the culture for Medicaid recipients. I want to spend a few minutes talking about measurement and how we at Medicaid see measurement, and then get into the specifics of what we are working to accomplish in our partnership with CareMessage. First of all, I just want to point out that we measure for a variety of reasons, and the reason that most people think about is measuring for accountability, and that's often measuring in our world at the state level to compare ourselves to other states or geographic regions within states. We measure health plans to see how they perform. We measure provider-based models of care, such as patient-centered medical homes or ACOs, to see how they compare. And we measure integrated models of care now more and more. We also measure, though I just want to say that that's what everyone thinks about most, but we also measure for quality improvement. And here in Minnesota, we've taken up some measures that we actually are a little bit homegrown around the amount of, big issue for us is the amount of opiate being prescribed. And we measure those at the provider level, or we ask providers to measure for the purposes of quality improvement in their own systems of care so that they then can understand what they're doing. And sometimes at our level, having as I'll talk about, having a provider organization measure for quality improvement is in some ways an infrastructure for us at the state level. We also measure to address and understand disparities, and one of the key issues that a lot of Medicaid programs are working on is to understand the disparities and then to focus programs on addressing them. And those disparities really relate to thinking of Medicaid not as a homogeneous population, but as a group of populations that have various social risks as well as medical risks. And then we measure for to affect policy, to go to our legislatures and our other constituencies to identify issues that we need to address. Measures appear on what I've what I think most people consider a validity continuum, that you can have an infrastructure measure such as the existence of a medical home, a process measure such as having a care plan inside that medical home, and a healthcare outcome such as improved diabetes outcomes as well. Those are all important, but as was just in the New England Journal, and I could probably any week pick up New England Journal or JAMA or the New York Times even and see quotes about the problem with the measurement infrastructure in the healthcare system. This from Porter, Larson, and Lee. Process measures don't truly differentiate among providers, so incentives for improvement are limited. Yet efforts required to measure processes and ensure compliance consumes organizations, resources, and attention. And certainly, the National Academy of Medicine, formerly called the Institute of Medicine, came out with this pretty groundbreaking vital signs report just less than a year ago that really calls into question the amount of process and infrastructure measures and really calls for us to move to measures of outcome in major areas. So that is all across the board, and virtually every week I'm sure many of you see articles that call on this issue. I wanted to propose something a little bit different here as we talk about this, and to think about extending this validity continuum. I call the beginning of this continuum deep infrastructure. And when we started talking about the healthcare home, I used to talk about, or the medical home as it's more commonly known, I used to talk about the healthcare home as being like a Rembrandt painting, and saying that you have 7% yellow in the painting will tell you nothing about whether the painting is beautiful or not. The same thing is really true here, where we need to look at deeper infrastructure, not whether or not you have certain criteria, but whether the criteria is actually meeting the family needs. We recently worked with Seattle Children's and Rita Mangione-Smith on developing a deep infrastructure measure called the Family Experience with Care Coordination, but those are, a lot of ways, patient-reported or family-reported experiences of care. And then on the other end of the continuum are measures of well-being. And those are things like the PROMISE measures that are developed by NIH, the CDC Healthy Days, the World Health Organization SF-12, that really talk about how people are doing in and around their communities. So this validity continuum needs to be extended, and I think the mobile technology gives us the opportunity to do that. The other thing I just want to talk about, just mention briefly, because this is what always snags us, is that claims-based measures are relatively easy to get at. We at Medicaid and most health plans all get their claims in and can see what comes through claims, but claims-based measures are often not everything we want. Hybrid measures look at medical records and claims, so a diabetes measure can tell you whether someone achieved a lower hemoglobin A1C and what the denominator of diabetes patients are, and there are some combination. And as EHRs come more online and meaningful use becomes more prominent, there's certainly an opportunity to use those. And then we have patient-reported measures, which we've talked about, patient-reported experience of care, and then patient-reported outcome measures. And those include measures of well-being and measures of functional status. And that's where the opportunity we're talking about today is. I think there are a couple important points to make about these measures. The first is that all of these are interrelated, but the same measure is not necessarily the correct measure for accountability at every level. Minnesota has piloted using the PHQ-9 as a depression survey, but the measure for depression remission is really around the number of folks who actually achieve depression remission, not actually an aggregated number for just the PHQ-9. Similarly, as I said earlier, collection and use of measures for quality improvement may be sufficient or part of a measure of infrastructure at a different level of accountability. So one thing we've looked at in Minnesota is the number of new chronic users of opioids to try to address the risks of prescribed opioids moving to addiction. That may be an accountability measure at the level of the clinic or the level of a health system, where underneath that we'll ask or we'll expect that providers will look at things like whether or not they screened for substance use before they did the second prescription, whether they created a pain plan, and a lot of other things that will in a sense, lead to a better aggregated measure. Patient-reported outcomes are one component, as we talked about. This is just a definition of a patient-reported outcome in the middle that talks about really the data coming in without an amendment or interpretation. And I think the next part is really important, is that patient-reported outcomes have the opportunity, which is really the unique thing about our partnership, to create a feedback loop to providers so that they can actually act on them to work with their patients. Patient-reported outcomes that we see can, again, are a perception of their patients, of the patient's care, and not of their healthcare experience. I mean, of their outcomes and not of their healthcare experience. I talk jokingly about patient-reported experience of care because when I go to the car dealership, I find that the folks ask me to rate them a 10 as they do their patient experience survey, and I'm acutely aware that if we create a measure with too much accountability or too much reward based on it, we have the ability to change people's perceptions and how they go about either collecting it or how they incentivize people to fill it out. So again, the experience and the patient-reported outcome have to match and be accountable at the right level. We look at patient-reported outcomes as useful for patient management if the collection is efficient, if the feedback can be prompt, if the tool is useful for that patient population. We also look at them as useful for quality improvement if they're aggregated and put into a clinic process, and if there is a clinic-level quality improvement process that they can impact. And they're useful at the state, MCO, and accountable care organization level if they're identify a key infrastructure component and are linked to relevant Sentinel measures. Our project with CareMessage is really, I would say, the start down that road because it's not very common that Medicaid programs actually go after patient-reported outcomes at all and then actually go after them in a way in which they're collected in an efficient way. Our goal with this project is really to test the ability of provider systems to use the text message-based platform to collect the patient-reported outcome and then to use that patient-reported outcome back into the system for patient management. We actually are very thankful for the grant that we received through the RX Foundation to do this work. And we are hoping then that we will, at the state level, just get the aggregated results without an accountability level to test the state program and to see whether or not this proof of concept works. Our goal is transformation. To change the current collection from a very slow, antiquated method that's highly administrative and very costly to an innovative method. We want to see whether or not we are able to collect PROs in this population and how efficiently, and we want to know whether collecting the PROs provides meaningful results. We haven't decided a tool. We hope to use an open source tool in this process because we feel like we'll be able to get feedback faster. Our partners, as I've said, are the CareMessage folks who have the technology and the platform, our clinical providers, our purchasers and payers, and then a PRO tool with a measure steward. There are some challenges in this work, as we'll talk about, I'm sure, and some of the questions that already came in relate to. One challenge is around consent for use of texting. Another is around delivery pulse. How and when do we send how much out to our recipients? A challenge of incentives for recipients, or whether or not we should use incentives to get folks to participate, and then the challenge that we talked about around clinical workflows. So, with that, this is a little bit of the the process we're using for recruiting and for identifying folks. And I'm going to turn it over now to Vineet, who's going to talk more about the mobile technology and the process and CareMessage as our partner. Thank you.
Thank you, Jeff. Appreciate the transition, and it's wonderful to have the opportunity to share a little bit about CareMessage and our work with the audience here. It's very exciting. So my name is Vineet Singal. I'm the co-founder and CEO at CareMessage. We are a nonprofit health technology organization based in San Francisco, and our focus is on helping healthcare organizations, particularly providers, in the safety net, federally qualified health centers, community clinics, free and charitable clinics, as well as payers, healthcare insurance providers, particularly those targeting Medicaid, managed care populations, to more effectively and efficiently communicate with these individuals, individual members and patients, to disseminate information, but also, as Jeff was describing, collect data and use that data in an actionable way that can be useful for the purpose of improving overall care. And I'll talk a little bit more about that later on in the presentation. The first thing I wanted to talk about is something that we all really understand, is the fact that I would say the most significant opportunity to make an impact for the AAA, as Dr. Berwick was talking about earlier in the webinar, is really amongst the low-income patient population, specifically because this population tends to have a much greater risk when it comes to the usage of emergency services and hospitalization services, a greater risk of premature mortality, and significant preventable costs that can have a very significant impact. And one of the challenges that many of the organizations have, as Erhardt was alluding to earlier in the webinar, is really the challenge of how do you do everything with just people? How do you complement the impact of people and humans and care managers with technology that can actually make them be more efficient and effective? And one of the things that we have realized at CareMessage is that the use of mobile technology, particularly the use of text messaging, is incredibly exciting. In fact, the use of text messaging in the United States, this is data from the Pew Research Center from 2011, which is the last time this type of data was released, is that the use of text messaging in the United States is inversely proportional to income and education, with lower income, less educated individuals using text messaging 2 to 4 times as much as individuals that are higher income and have more education. Text messaging also has a 99% open rate versus 28% open rate for email. So it is definitely the most ubiquitous and most inexpensive form of communication by far out of all the different modalities of communication. And what's also really interesting and exciting is that there's over a decade's worth of literature that demonstrates the viability and possibility of text messaging and improving care outcomes for diverse patient populations, particularly those in the lower socioeconomic strata. This is a study published in Health Affairs. This is a study that shows that from the University of Chicago that demonstrates with statistical significance that the use of text messaging saved on average about $400 per patient per year in preventable costs tied to improved glycemic control for patients with type 2 diabetes. And there are many other studies focused on smoking cessation, focused on preventative hospitalizations, ER utilization, et cetera, et cetera. So CareMessage, just to kind of give an overview of the tool that we have and a variety of different applications that we're able to offer this tool, is essentially an intelligent cloud-based technology platform that takes the possibility of using mobile-based messaging, particularly text messaging, and essentially enables any healthcare organization, but particularly targeting organizations that are serving Medicaid and uninsured patient populations, for the purpose of enabling these organizations to integrate this capability directly into the clinical systems and workflows that they're already using. So whether a provider is using an electronic medical record system or a health plan is using a care management system, our technology essentially acts as an extension of that capability and enables these organizations to embed and integrate mobile-based messaging directly into what they're already doing. And what's really exciting is that it uses the most modern forms of web-based communication modalities for the purpose of enabling these organizations to embed this capability directly into their daily workflow. So for the healthcare organization or the provider, the interface is intuitive, it's web-based. It can also be deeply integrated into what they're already doing. There's no IT management required, so IT, for the most part, doesn't need to get involved except during the initial integration piece. There's no maintenance required from the IT staff, and then for the patient, which is the most important component in this value chain, the exciting thing is that this does not require the use of a smartphone. So text messaging works on any device with text messaging enabled, which is the vast majority of devices in the United States. And what's also really exciting is that the vast majority of the population that we're serving has access to unlimited text messaging. In fact, the research shows that that number may be as high as 80% of individuals in the Medicaid and uninsured category have access to unlimited text messaging on their mobile devices, which is something that enables them to use this as a channel of communication with their provider, with their plan, and not have to do anything extra like install an additional application. This is behavior that they're already doing in many cases multiple times a day, and this is just an extension of that behavior when they're communicating with their provider, when they're communicating with their plan. So the different ways in which CareMessage operates and the different things that we offer our providers and our health plan partners, obviously one of the major use cases is reducing no-shows through automated appointment reminders. We also enable our partners to be able to follow up with patients or members regarding specific preventative visits, specialty referrals, prescription refills. There was a recent meta-analysis study that showed that the use of text messaging can double medication adherence for patients, and we're doing a number of studies tied to that particular outcome. We already talked about data collection, and Jeff talked about it in his presentation about patient-reported outcomes, but then also collecting data around patient satisfaction and patient experience is really important. And then finally, the most significant part of what we do is really enabling care management and disease management protocols to be more effective and more impactful through the use of automated messaging that is designed to essentially initiate some sort of behavior at the end of the day with the patient or with the member. So whether that behavior is helping the patient learn about how to do a foot exam if they have type 2 diabetes, or how to quit smoking, or how to manage their insurance benefits, whatever that behavior that we're trying to incite with that population, or whatever that knowledge it is that we're trying to imbue with the patients that we're trying to work with, we can have different interventions, and we have developed different interventions that can help our partners to be able to have that outcome at the end of the day. So in addition to the core technology platform, we also offer these individual programs that are specifically tied to a particular behavior that we're trying to incite within the population. And just as an example of some of these programs, this is our diabetes program, which is specifically focused on helping the patient, guiding them through the process of managing a difficult chronic condition. One of the things that we have realized in the over 160 healthcare organizations that we're working with right now is the fact that many of the patients that we serve often don't understand the basics of their condition, and often don't understand what it means to have a chronic condition, whether chronic means something that's ongoing or chronic means something that is life-ending. And obviously we want to make sure that patients first and foremost have a positive attitude about their condition, that they are in a position where they can actually manage their condition in a positive way. Obviously education is a very critical component, so our programs actually help guide the patient in an automated fashion based upon their answers to specific questions. So as an example, using the foot exam as an example, I'm asking the patient a question of whether or not they know how to do a foot exam at home, and then based upon their answer, either asking them if they've done a foot exam in the last 60 days or the last 90 days, but also teaching them how to do a foot exam if they don't know how to do a self-exam. And then relaying that information back to the provider, relaying that information back to the health plan as necessary. And then obviously empowering them with the tools and information that they need to take control of their health care. I'll talk about one specific example. We have a study underway at Stanford Hospital focused on women that are on Medicaid and are also pregnant and at risk for postpartum depression, which is a significant portion of women. And we recently implemented a technology feature that enabled the provider on the other side to receive a notification every single time a mom responded yes to the question of if she's feeling down or if she's feeling depressed. And what happened most recently was the fact that we indeed had a situation in which a mom who was feeling depressed was asked that question and she responded yes. And the doctor on the other side was immediately notified, and that doctor immediately called that mom to address that situation. And that's something that would not have happened without the constant communication that we were having with this individual mother for the purpose of essentially assessing if she was at risk for postpartum depression and the eventual consequences of that. So this was something that was really exciting and just an example of the applications that the technology can have to, again, extend the impact, extend the reach of human beings. The other thing that's also really exciting about the technology is that our partners have the ability to build their own campaigns. They can actually build their own capabilities. And this is just one example from a diabetes perspective, the ability to build these automated programs that enable our partners to be able to, essentially using branching logic, be able to disseminate specific types of information, but also collect and elicit specific types of data back from the individual. And essentially creates a smarter, more personalized interaction with the end user. I think Don Berwick's earlier comment about how do you standardize something, but how do you actually personalize it at the same time? This is kind of our attempt at doing that, particularly from a messaging perspective. Obviously, targeting comorbidities, we understand that this population does not have sort of a one-size-fits-all approach when it comes to chronic disease management, and we understand that many of these patients have many different conditions at the same time, and also understanding that they often struggle with many of the underlying social determinants of health. So in the messaging that we provide to our patients, not only are we addressing the fact that they may have comorbid conditions, but also the fact that they may not have access to a kitchen where they can cook, or they may not live in a neighborhood where it's safe to go outside and exercise. So how do you address some of those barriers in the information that you're providing to the patient, in the resources that you're recommending to the individual at the end of the day? We take into account a lot of these different types of variables in partnership with the organizations that we're working with. And then obviously understanding that the key design principles of the work that we do is really human-centered. It's really about the individual patient at the end of the day. We interview hundreds, if not thousands, of individuals on a regular basis to really understand how they're doing, what are some of the core challenges that they're facing, and then take those insights, take those learnings, and embed them back into the programs, really focusing on extreme users, individuals that are really struggling on a regular basis to meet their basic needs that are influencing the way in which they're managing their health, and making that experience extremely tailored and personalized, obviously leveraging clinical expertise and the best-in-class evidence base. And then I wanted to talk about very quickly some of the data that we have seen from some of the implementations that we have run in the past. So one of the implementations that we had was at a managed Medicaid plan based in California, and we essentially doubled their ability to reach their patient population when it came to Medicaid re-enrollment. So essentially assessing which of their individual members needed help with re-enrollment, and then helping them with that re-enrollment process. The first step in doing that is actually getting a hold of the member, and we essentially doubled their ability to do that, leveraging CareMessage. We also had a large federally qualified health center in Los Angeles that had a increase in their recall rate by 40%. For patients that have been dropped off their eligibility list. So this is also really about engaging individuals that have been disengaged for a long time and getting them to come back to treatment. That's also a pretty significant use case for CareMessage. Many of our organizational partners have seen significant reduction in no-shows. There was a recent evaluation that showed that implementing CareMessage increases the likelihood that a patient will show up to their appointment by about 1.8x from baseline. And then another community clinic in Brenham, Texas, showed a 20% drop in their no-shows after implementing CareMessage, and the drop was consistent across multiple quarters. And then on the health outcomes and care management side, a Packard Foundation-funded evaluation at a free clinic in San Francisco demonstrated significant outcomes. 94% of the diabetic and hypertensive patients reported that CareMessage helped them better manage their health. And a recent pilot study that was NIH-funded and Stanford-led, 94% of sedentary patients increased their physical activity over the study period based upon accelerometer data, essentially pedometers, using CareMessage. And I think at the end of the day, the most important aspect is how does this make individual patients feel, and how does this actually impact the way in which they live their daily lives and actually interact with their healthcare on a regular basis. And this quote from one of our patients that sometimes it only takes one word if you're down to elevate yourself. And I think it's just emblematic of the fact that many of these patients are actually hungry for more information and more support and more accountability. And CareMessage is one tool that can help them get there. So that's something that we're really excited about. As I was mentioning before, CareMessage is a nonprofit organization that is funded by institutional and individual philanthropic investors. We have essentially a sliding scale pricing model with organizations that have the ability to pay for our technology, that pay a standard fee, and then organizations like free and charitable clinics and community clinics pay a very nominal fee or pay nothing at all. And that enables us to serve a wider range of healthcare organizations that can ultimately leverage and benefit from our technology. And thank you so much once again for the opportunity to share a little bit about our work, and looking forward to answering any questions they might have.
Thank you so much, Dr. Schiff and Vineet, and to all of our speakers. We've heard a lot about different ways mobile technology is being used to reach the Medicaid population, and I think they all have some common themes of a focus on improving health outcomes, reducing costs, and also increasing the productivity of the healthcare workforce. And we are now going to turn into our Q&A system. I'm going to ask our operator, Steve, to come back to explain how you can ask a question over the phone if you're joining us by phone. And if you're just joining us on the web, you can continue to post your questions in the Q&A box on your screen.
At this time, I would like to remind everyone, in order to ask a question, press star, then the number 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster.
Great, thank you. I'll ask a web question while we wait and remind our speakers that they can take their phones off of mute. A couple first questions going back to Erhardt's presentation. We had a few questions coming in about how you're leveraging your mobile technology to track the hours for the personal care assistants, and also how you address any regulatory and legal challenges related to the use of the technology and the notion of no cost to the member.
Let me do the hours piece first. So really the hours that the personal care assistants are using, so there's two things. One is we help set the hours through our own assessment. So we sort of go through a very detailed assessment. We understand what the member needs, and then so we sort of set the hours there. And then through this pilot, we're now able to verify the actual tasks that are done. We can tell how many feet away from the front door that a PCA checks in and how many feet away from the front door they check out, how quickly they got to the front door if they checked in sort of 400 feet away, et cetera, et cetera. So we can get some really good data to sort of verify that they were there, what they were doing, et cetera. So it's a whole new layer of visibility into what's going on. The second thing with regard to the legal aspects, I mean, obviously, we've been very clear with understanding what's clinical, what's not clinical, where sort of the guidelines are between the questions that can be asked one way or the other, and have obviously had our lawyers sort of review everything in grave detail. I don't know, Jerry, would you add anything?
Yeah, and we follow our internal processes to make sure that, no PHI information is going outside a unit. So we have one feed. We feed our information directly to Beata, and they're the only ones that see that information. And we've made sure that they have the security necessary to meet our demands to secure that information.
And obviously we may have made it look easy when we went through the slide, but as you can tell, or the person that asked the question knows, it's a little bit more complicated than what we showed.
Great. We also had a question, if you could just explain a little bit more about the personal care assistant and who you define as a personal care assistant, just to clarify for the audience.
Yeah, no, that's a good question, and they are called sort of different things in different states. So this would be somebody that goes into the home that does I'll give you my non-clinical speak. They don't really touch the member. Maybe they help with basic activities of daily living. They help with doing chore, maybe some bathing, but they don't do the highly skilled wound care. They're not clinical people. Basically just somebody that helps them to live in the home more independently. Is that fair, Jerry?
Yep, that is fair. So they wouldn't be administering any medications. It's not a skilled need that they're there to meet. They're just there to meet the activities of daily living. They'll do shopping. They'll do cleaning. They'll do some cooking for the member if they're not really able to cook for themselves. You know, as Erhardt said, they'll do the bathing, the dressing. That's a personal care assistant.
And you'll typically, within Medicaid, the aged, blind, disabled Medicaid beneficiaries, as well as the long-term care Medicaid beneficiaries, you'll see this personal care concept or provider set used very often. So it's definitely something that's out there in a pretty big way.
And especially within the MLTSS program, the PCA workers, they're key to our ability to keep these members independent and in their home rather than having to transition them to a nursing facility. These positions are really what keeps the member out in the community healthy, making sure that they're independent as can be within their own homes, or supporting the caregivers.
Great, thank you. Operator, do we have any questions on the phone?
Again, if you would like to ask a question, press star, then the number 1 on your telephone keypad.
Great. I'll keep going with the web questions and just jump in if there's any coming in over the phone. We had a question, and I think probably for any of the speakers, what are some of the ways you found useful in addressing the social determinants of health like food security and public safety? I think food specifically was mentioned in both the presentations, and Dr. Berwick, feel free to jump in from your perspective as well.
This is Erhardt. I guess I'll make a quick comment. I think the social determinants are probably the very first thing that we actually look at in most situations. As we all know, if somebody is wondering where they're going to get their next meal, they're going to be less worried about getting some type of a preventative test with their primary care physician. And so we educate our staff. We've got tons of community partnerships where we are able to really build and understand how we overcome and address the social determinants first. And this is not a commercial, but I will say on our website, horizonnjhealth.com, we have some outstanding stories about members that were homeless or members that had other issues that needed social help before we could address their medical issues, and we see it over and over and over and over again.
This is Don Berwick. I'll build on that. I mean, I think one of the important perceptions here, and I'd love to know what Jeff and Vineet think, is not to see mobile technologies as a freestanding, separate, disconnected, and highly effective intervention, absent its embedding in a larger concept of the nature of care itself. This question is asking about connection to food security and public safety. Think, for example, of Rebecca Oney's breakthrough in developing health leads, linking health care to social supports, very directly with very great services. Think about how mobile technologies and that reconceptualization interact. So I personally, as excited as I am about mobile technologies, and I couldn't be more excited, I'm even more so when I think about them as a brick in a larger building, which is the reconceptualization of care around production of health and empowerment of patients and meeting them where they are. Without that, we're asking for magic. But with it, we really can have tremendous change.
This is Vineet. Sorry, go ahead.
Oh, Vineet, I'll just stick in a comment in real quick. I agree completely with Don that I think the real opportunity here, and where we went to recruit provider organizations for this proof of concept with CareMessage, was first to our accountable care organizations, because these are people who are already working on integrating and looking for better results. And I think that, as Don said, and I couldn't agree more, this has to be lined up with the providers who are providing the care. What this does, though, is it gives a tool for what we think of as traditional clinical providers to integrate, as Erhardt said, with other organizations outside in a way that gives providers an opportunity to work together in a more meaningful way. And then I think what I think is really unique about this is the opportunity to get that feedback in a regular and ongoing and very quick loop, so the intervention can meet the needs of the recipients much faster.
Exactly, and the only thing that I would add to that is including resources, including information that is contextually relevant in the actual information that's sent to a patient, whether it's disseminated in the case of Horizon by a care manager, or in the case of what we're doing, sent as a text message. For example, when we work with local organizations in San Francisco or in Texas, we work with these organizations to really understand if a patient has a concern about getting access to healthy food, what are some local Meals on Wheels services that are available to make sure that this individual has the ability and the resources that they need to get to that resource, to get access to that information. In other cases, we have leveraged the power of connecting these individual patients and members to transportation services. For instance, if they're not able to make it to their appointment because of a lack of transportation, how can you make that information available, accessible, and then ultimately actionable, so that an individual who is not able to access transportation can just very simply by a basic text message indicate that they need transportation services, and how can that text message or that information be made available to the person on the other side and then take action. Really connecting the two, but then making it contextually relevant based upon the local circumstances, the geographies, et cetera.
Great, thank you all. As a follow-up question, someone has asked if you could talk about any of the barriers that you see to this important integration with community services, either with integrating with mobile or more broadly as we've been discussing.
This is Jeff. I'll start. I think one of the challenges that came up on some of the online questions I think is really relevant, and that's there is a barrier we have to work through overcoming around consent because of HIPAA and other privacy issues, and really have to figure out how to get consent up front for these. That's one thing. I think then the other things are really around how the clinics work this into their workflow, and I think some of the work that Vineet and his team have done around that can help reduce those barriers, but it still will require some resource and some reallocation of resources at the clinic system level to be effective.
This is Don. Part of this relates to teamwork. The concept, in my view, the concept that there are payers and then there are caregivers, and they're never the world shall meet, won't work here. We need imaginative payers able to work hand in glove with care delivery designers and clinicians, like you're hearing on the phone today, to view payment as a mechanism for changing care, not passively but actively. When I was administrator of Medicare and Medicaid, I will tell you it was difficult. We could see the frontier of possibility, but within the current regulatory, statutory, and sub-regulatory environment, it was difficult to find the daylight to say, oh, we really can help accelerate this development. That's mandatory, both on the commercial and the government side, in my view. I think there's progress in some of CMS's latest steps, especially with respect to the advanced ACOs, is starting to break some new ground on making this kind of innovation not just possible, but really smart. And I really hope that process continues.
Great, thank you. A few questions I'm going to try to combine together. If you all could talk a little about either successes or examples or how you're doing this in terms of using this technology and working with the blind, age, and disabled population who, may not be as inclined to use text messaging, as well as, engagement among non-English speakers or, limited English proficient population, and sort of any special considerations or efforts that you're doing among those populations.
Sure. I think I can get started. This is Vineet. A couple things. The first one is, for maybe even stepping back, accessibility is the cornerstone of what we do. We understand that health information in particular, isn't very accessible, particularly to the patient populations that we're serving. So a couple things that we've done. The first is implementing voice communication in addition to text as another form of communication, enabling individuals that are blind or individuals that are illiterate, being able to have them be able to access that information via a voice message in addition to a text message, and enabling similar interactions via a voice channel. The second thing is optimizing for individuals that are non-English speakers, which tends to be a significant portion of the population that we're serving. So particularly Spanish-speaking individuals, every single message that we write is written in English and Spanish independently, so that there's a process by which we're not only translating the meaning of the information that we're translating, but we're also contextualizing that information and making that accessible to the population that we're trying to serve. So it's not a direct translation. It's essentially contextualizing the information as much as possible. And then most recently, we've enabled the use of CareMessage in about 30 additional languages beyond English and Spanish, so we can reach a wider base of the population that we're trying to serve.
This is Erhardt. Just a couple of comments to add. So first of all, we've got the scale and the size to be able to do this. I realize not everybody does this, but we very purposely hire from the communities that we serve. We very much understand the demographic that we're serving, and seek to hire native speakers and be able to pair them with the appropriate people. It's worked quite well. I think we have something like 13 languages spoken internally or something like that. But then the other thing, contracts always require having language lines and having all of your materials written in multiple languages. We certainly have that. But I'll tell you something that winds up getting used, and this has been in other jobs that I've had as well, is Google Translate. And it works quite well in situations where you don't have a native speaker, which is clearly the preference. But people wind up using that quite often. So.
Great, thank you. A few other questions came in also about how you use technology with adolescents and sort of overcoming the barriers of working with minors. I don't know if Vineet, maybe are you working with have you worked within that issue with them?
Sure. Yeah, absolutely. Actually, our first partner ever was the Lucille Packard Children's Hospital in Palo Alto, California, and we're specifically working with a mobile health van that's addressing adolescent health and some of those issues. I think from our perspective, what's really exciting is that obviously the use of mobile technology in this demographic is extremely high, particularly the use of smartphones, even within Medicaid and uninsured demographics is very high, close to 80 to 90% smartphone penetration. But what's been very surprising, and something that I think is indicative of the fact that we make a lot of assumptions about the populations that we're trying to serve, but when we actually dig in and actually look at the data, it's very different. Is that the perception and the receptivity to health information and receiving and engaging with the healthcare provider using mobile devices is very high. And I think it's something that's reflective of the fact that many individuals and patients in our healthcare system feel I think that there's a sense of feeling isolated and feeling removed from the healthcare system, and feeling like there's not a lot of accountability, and there's not a lot of care, particularly outside of the four walls of the clinic or the hospital. And so to the extent that we can make that available to as many individuals as possible, whether it's through a care manager that comes into their home and actually helps them take care of meals and provides them with the support that they need, or whether it's through a text message or a combination of the two. It's something that we see reflected in the elderly population. It's something that we see reflected in the middle-aged individuals, but certainly something that we see reflected in adolescents, particularly around use cases that are relevant to them, whether it's obesity-related concerns, whether it's pediatric or adolescent asthma and the adherence to that, or whether it's sexually transmitted conditions, et cetera. Those are some of the things that we think and have experience with in terms of improving adolescent care.
Vineet and Jeff, what about elders, especially frail elders? Are these technologies useful to them?
In our experience, Don, one of the things that's been really interesting is that with the elderly population, obviously the use of mobile devices in this demographic is high. It is not obviously as high as individuals that are on the younger side, but it is still very high, and it's something that enables us to directly engage. I remember a couple of years ago, we had a patient that was 95 years old that enrolled in one of our COPD interventions. So we definitely do see that as being a possibility. But also, I think within that population, in addition to directly engaging the patient, we see an incredible opportunity in terms of empowering the caregiver, and essentially whether it's the daughter or the son or the granddaughter or a family friend or someone that's responsible for taking care of that individual, and really how do you empower that person to make sure that person has all the right information and resources, and that person feels empowered and in control when it comes to taking care of their mom or taking care of their dad. That's something that's really important, and that's where we see the applications of these types of technologies maybe a little bit more exaggerated than in terms of directly engaging the patient.
So, Don, just to add to Vineet real quick, we have an organization out here that does care mostly in assisted living and skilled nursing facilities, and they've developed a mobile platform that is a bridge, and they use it specifically to connect their providers who are actually in the group homes or the facilities on an intermittent basis with the caregivers in those facilities, and then with the family members as well. So it works well if it's 3 miles away or if it's across the country. And that's gotten it's a great communication tool designed really to make sure that everybody's in the same loop all the time. And to your point about changing the balance of power, it really gives the information directly to family members simultaneously.
Thank you all. We have about 5 minutes or so left, so a bunch of questions. We're going to try to keep going through some of them. Erhardt had mentioned sort of an incentive to the personal care assistant. We had a few questions come in about other uses of incentives to increase sort of adoption and engagement with mobile technology, and also specifically the CareMessage technology programs, especially given the high rate of churn among Medicaid members. Could you kind of talk to the difficulties of engaging participants and kind of being consistent through the programs?
Part of what I think was important, and again, if all providers are important, but personal care assistants specifically, most of the time don't get paid very much. And there's always an ask to figure out how we might get more money into that provider set. And so, quite frankly, this is being able to pay quality incentives covers off a couple of different things that we want. One is getting more money into this type of provider. And so engaging people and figuring out how they're able to make more money works out very well. The Medicaid churn that you're talking about is probably less so in the aged, blind, disabled, and the managed long-term services and supports. And these are the populations that typically are served by the personal care assistants. So probably not quite as big of a deal. During our test, what we really wanted to know was if we paid some money Would it be important? Would it get their attention? And would we be able to influence an outcome? That's what we were really looking for over that 6-month pilot, basically. And I think based on all the data that we're looking at, the answer is a resounding yes. And so we're going to tinker with that. Literally, we paid some money to get people to visit PCP. So we're going to tinker with that some more and see where else we can go. But that very first sort of theorem was proven in our eyes.
One thing that I just wanted to add on the topic of incentives, obviously there's a huge amount of value in incentives that are monetary in nature, or have some sort of benefit, whether it's coupons, whether it's gift cards, whether it's direct incentives to a premium, etc. One of the things that we have experimented with in our programs, not very directly, but sort of at a sort of a deeper level, is really the incentive tied to accomplishment. And particularly in our programs, when we implement a diabetes program, for instance, with a patient, we often have messages that say, you have completed 2 weeks off the program. Congratulations. Now we're going to talk about, insulin management, or now we're going to talk about medication compliance. And then they complete that program, and that they get a congratulatory message. We're still doing a lot of research into this. We have a research team that's dedicated to actually collecting some of these insights and some of these learnings. But sort of intuitively, when we talk to our individuals and our users, and we have conversations with them, one of the things that they often talk about is the fact that it made them feel the sense of accomplishment that they've completed something, and that sense of accomplishment translated to them really internalizing that information, really treating that information as something that they should be thinking about on a regular basis. So even though it's not a direct monetary or very specific tangible incentive, just the fact that there is this sense of accomplishment, the sense of completing something tangible, even though it's a 2-week text messaging program, is something that we're still continuing to do more research on, but it's something that we're thinking could be a very powerful incentive when it comes to getting members and patients to be able to continue to have sustained engagement with some sort of program or messaging capability.
The last quick thing I'll add is the PCA workers, the personal care assistants, they loved, so money aside, they love feeling like they were a part of the care team now when they had the ability to give this information and to drive quality and do this other stuff. We heard that over and over and over again. They were just excited to feel like they were a part of the care team instead of coming into the house and just doing chores or bathing or dressing or something like that. We got that a resounding number of times.
Great. Thank you all. We are almost at 2:30, so I did want to allow our speakers sort of one last opportunity to make any closing remarks, and potentially perhaps you could share with us sort of one policy or payment reform or delivery system change that would really help improve or enhance the use of mobile technology either in your program or more broadly in the near future. And maybe we could start with Dr. Berwick.
Yeah, I would like to see more experiments with payment so that this stuff could take off much faster and with critical assessment. And as I've shared with Vineet in my own conversations with him, these programs need evaluation. The evaluations are underway now. I think they'll be very reassuring. I'll bet that 2 years from now we'll look at this as absolutely inevitable in the armamentarium of care.
Thank you. Erhardt?
The one thing I'd add to my earlier presentation is obviously the state of New Jersey has been a wonderful partner, and that's critical in being able to use technology and pilot different things and have a great program. The technology, mobile technology specifically, in the way we view this in the pilot that we talked more about, is allowing us to be more aligned and to drive payment innovation and essentially move money into what I think is an underserved area. And we wouldn't be able to do that. We wouldn't be able to pay for quality if we didn't have this technology. So it really is the cornerstone to moving this forward.
Thank you. Dr. Schiff?
Thanks for letting me participate. Just a couple of things really starting. like it if the technology came more nimble with time. Go ahead.
Could you speak up a little bit? We're having a hard time hearing you.
I moved my microphone earlier.
Thank you.
It would be great if we could have this technology be more nimble over time, so that we can have, for example, one of our providers at Hennepin County in Minneapolis, or one of our big county hospitals, looked at housing insecurity and found out how to identify folks who are housing insecure before they get to the point of being homeless. And so the idea and the ability to use this technology in a nimble way, I think, is something that really provides the opportunity for providers to experiment, to actually serve their patients better. And then I want to reemphasize what Erhardt said, which I think is really important, is financial incentives are really important at some levels, but they won't, we think that if we can give folks to have a sense of belonging and a sense of participation in the care processes as providers, they're going to be much more empowered and interested in using the technology.
Thank you. And Vineet?
Yeah, thank you so much once again for everyone that participated in the webinar and for asking these very thoughtful questions. There were a few questions I was looking through the list of the Q&A log that had concerned with PHI and the question of HIPAA and regulatory questions like that. And if anyone has any more questions about that, I'm happy to talk offline. You can submit a request to our website, caremessage.org. I'm happy to chat about that. But specifically from the perspective of policy, one of the things that I would like to see possible would be more direction and guidance from ONC and from sort of the regulatory bodies that oversee HIPAA and TCPA around the use of mobile-based technologies, including text messaging, but other forms of applications and technologies, so that there is not a lot of uncertainty and questions around some of these things, that there's very clear guidance on how and when and in what capacity these technologies can be utilized. So to the extent that that information and guidance can be made available so that we can usher in this new era that we've been talking about, I think would be very helpful, particularly to technology providers like CareMessage.
Thank you all so much for joining us today, both to our speakers and our many participants. And if you'd please take a moment to share any feedback on this event with us. There's a link on your screen, the SurveyMonkey link. We will be, the slides are on our website, and we will also be sharing a recording of the event within the next week or so. So thank you all again for joining us today.